Hello, and welcome to this installment of Frank and Mary in Westborough. With me is my good friend Shelby Marshall, as you know, my co-host, and the purpose of this show is to be talking about things that you ought to know about, things that Frank and Mary ought to know about if they're living here in Westborough, things that you ought to know about, and people you ought to know about if you're a senior living here in town. One of the people that Shelby suggested you really ought to know about here in town is my old friend Danielle Gregoire, who is your state rep, but also is from my hometown. So, but with that, I'll have Shelby go from there.
Well, it's a pleasure. Thank you so much for making time out of what is a currently busy schedule, given the time of year.
Thank you for having me.
So first, let's give our viewers a chance to get to know you. So who are you? Tell us a little bit about yourself, please.
Okay, great. So I am Danielle Gregoire. I've served precincts 1 and 3 here in the town of Westborough, along with 2 precincts in the town of Northborough, and 10 precincts in our home city, Arthur, of Marlborough. I'm a lifelong resident of Marlborough. I'm in the 5th generation of my family to live there. On my mother's side, we all went to the Marlborough Public Schools, and I'm just really proud of our city and what we've been doing, and have gotten to know Northborough and Westborough over the last couple of years. I served as a legislative aide to the state rep who served prior to me. His name was Steve Leduc, for 5 or 6 years, 6 or 7, while I was going to law school in the evenings. I did end up graduating from law school and passing the bar exam, and the timing worked out so that I ended up running for that seat way back 10 years ago in 2008.
Right when Steve left.
That's right, and the makeup of the district was a little
you were
different.
like 17.
Yeah, thank you.
Yeah, because I'm adding up these. I'm adding up these years, and I'm saying, so this very young. Doesn't she look so young?
I'm aging in reverse.
And this is like 18 years she's been
That's a different
involved
show.
in politics.
Aging in Reverse.
That's
By
right.
Danielle.
That's right. We'll do this.
So
It's the sequel to Reverse Mortgages. Reverse Aging.
I jumped right into the race, and here we are 10 years later, and this session I was appointed by the Speaker of the House to serve as the chair of the Joint Committee on Elder Affairs, which is why we're here to talk to you folks. It's been an unbelievable journey in between getting to know all the residents of the communities that I've represented outside of Marlborough, because I consider myself to be a little bit of an expert about Marlborough, but I've learned a lot in the last year and a half on aging and elder affairs. I wasn't even on the committee prior to being appointed its chair.
I remember seeing you when you would it was like you were a weekend. You were like, we got so many things to do, and you had people coming in to try to brief you.
It was a learning curve, and we got briefed by everyone, and I think it ended up working out really well, and we got some unbelievable things done this session, which we'll talk about as the show goes on.
So government can be sort of overwhelming unless you're sort of a junkie and you love to kind of follow that. Tell us about what that office is. What is the purpose of the Office of Executive Elder Affairs?
So we're the Joint Committee on Elder Affairs, but we do work with the Executive Office, which is the administration, and as some people in town probably know, the Secretary of Elder Affairs, Alice Bonner, actually is a Westborough resident. So the town of Westborough was very well served by its Elder Affairs faction, I suppose, if you will. And we work hand in hand with them. So any of the legislation that we were considering moving forward, we would reach out to them and see. Okay. Or the Department of Public Health, whoever it was, so usually in conjunction with both. But we worked hand in hand with the administration on anything and everything that we did this year. Okay. So it was a really great working relationship, and I've never really met anyone like Secretary Bonner. She has the most energy and the most passion and drive for what she does, and it has been really great to get to know her and work with her.
It's great to have a secretary who's just totally been in the trenches, and then have a mother, who is still alive, that she's still a caregiver, so it just changes the whole way that people approach things.
No, she really understands.
She's one of the most incredible people I've ever worked with, really. It's been an honor.
So tell us about, sort of what that year of experience has been serving as chair and some of the results.
So at the beginning it was, just brass tacks. What are the bills that have been assigned to our committee? Because by the time we got our assignments, the bills had already been placed there. I was lucky.
What do they say?
What do they say? What do they do? Who's this agency? Who's this activist group? Right. I was very lucky as a first-time chair that it was a small amount of bills.
Like what's a small?
Comparably. So we were somewhere in the neighborhood of 80, whereas say like the Committee on the Judiciary would have 600 or 700.
Wow.
So it was a nice starter committee, I like to call it, for me.
And that, again, for our audience, that's to consider in what period of time? So 80 starting, that's across a year?
Technically, it goes through what we call the Joint Rule 10 deadline, which is when all of the bills have to have had some sort of action taken on them. And this year, that was this session, it was the second year of the session in March. Now, of course, you can.
Because the session is just the 2 years that you're
the
elected for.
That's right.
And we just had an election, so that means that the session ends, right? Just like in
So
December.
our
right?
session is constitutionally mandated to have completed action on any bill that may be considered controversial by July 31st in the second year of the session.
Wow.
I see. But at least you became chair, like, that was last year.
Yes,
So
and it was in February. So
so
we
you
had a
got all the
full year
bills-
and a half to
Right.
kind of get our feet wet. And I was very happy with the outcome on most of the things. There were a couple things we weren't able to get over the finish line. But as people know, sometimes these sweeping legislative policies take some time. So I have
Right.
a good feeling that we'll be in a good place starting next session.
So tell us about some of the results you're most pleased with.
So obviously I'm
Or
really...
even the ones you hate. You know, you can tell us about.
I will
mean,
tell-
Arthur, this
I
is
will-
a happy show. We don't.
No,
this
we
is,
want
you know,
serious. You know,
I will talk
she's
about
running,
it.
she's
can
running
attack
for
here.
office again
You can,
here.
you know, yeah. Well, that's right.
We had a couple of failures
except
where
for
we
that.
just
You're running
we
for
had a
office.
couple failures where we just ran out of time,
Yeah.
and they're bills that I think are vitally important, and I do
Yeah.
think we'll get a running start with them in January.
Because you'll need to
if
refile
we're
them
reelected.
and then it starts
That's
again.
right. So
I see.
one was a bill filed by my colleague from Worcester, Jim O'Day, to start a building fund for senior centers, and it was
Oh.
just without examining a revenue source or anything
Yeah.
like that. So we changed the wording of it to do a commission, a 6-month commission, to study what it would look like to create something like the school building authority for senior centers.
So that you could provide matching or
So
something.
it would
Yeah,
have
yeah.
been that commission that would have been tasked with finding a revenue stream and, you know, coming up with potential rules and regulations by which that
Interesting.
group would operate. So
Because one of the things I've come to learn from doing some stuff in some other states is that we are one of the only states where you've got separate councils on aging in each community. Most states don't have that. All this stuff is all run regionally.
Okay, yeah.
And so it's much less friendly to
Sure,
seniors,
sure.
as a result.
Right.
So that was one of the bills, and I do think like I said, that has some legs. We just didn't have time because
Yeah,
we were
sure.
considering so many overwhelming bills at the end of the session. A second piece that I worked on a lot that I would really like to see come to fruition has to do with assisted living facilities. So currently, if you reside in an assisted living facility and they have a nurse on staff, that nurse is not allowed to provide you any medical care whatsoever.
Right.
Even though they're
Do we know
required to
these?
keep up their
Yes.
licensing
Yep.
and keep up all of they're still a registered nurse. They are not allowed under the current bylaws because, like with the senior center building, Massachusetts is unique in that we regulate our assisted living facilities under the Executive Office of Elder Affairs rather than the Department of Public Health, which oversees nursing homes.
Sure.
So we had a bill that would have allowed those nurses to provide basic medical services, wound care, injections, and eye drops.
Which, sort of having that experience, most families, when they go in and they're looking for care for their loved one, they think, oh, this is the place. And even if they hear it from the assisted living executive director, the clinical director, or what have you, even if they say, understand we can't do X, Y, and Z,
Right.
they still think
They're not
this is
hearing that.
they're not hearing it, because they're in
because
such
they
a
see the nurse.
absolutely, and it's a shock. Like,
So
what
I
do you
had
mean?
a colleague from the Berkshires who was paying 5 times a day, $90 a visit, for a visiting nurse to come give his father insulin. And it's not necessarily because the patient can't mentally handle it, it's because they can't physically
Right.
load and the nurse can't even prepare the injection.
Right.
So basic health services was one thing, and we negotiated it until the cows came home, and we were just there at the end, and again, it got lost in the shuffle of all the other bills that were being negotiated.
Yeah,
Yeah.
So it's something that I think it's really important in moving forward. It's something I'm going to advocate for.
absolutely.
Just stepping back to just for a second. So did anyone oppose it, or was it just
So-
one of those things that you just kind of ran out of
So
time?
interestingly, there were assisted living owners that opposed it,
That opposed it.
even though they were members of the Assisted Living Association. And depending on where we were with the wording about the requirement for the nurses, at times we had the nurses on board and at times we didn't.
Sure.
So, it was a constant
That's the process.
fluid
Yeah,
motion
I was just gonna say.
and a constant back and forth.
Yep.
But I think we'll be able to get there eventually because
yep.
it's called the Common Sense Healthcare Bill, and it seems to be so common sense
Right.
that you have a nurse there and you should just let them do their job.
Right. Well, because you really, doing a dial on a diabetic, anyone can really do
Right.
that as long as you understand what the sliding
Right,
scale
a
is.
family
and
member
a family
legally
member
right
do
now
it, but
can
you have
go
a
into
nurse
that
in a
assisted living and do it.
facility.
Yep,
Yeah, so
absolutely.
A family member can do it.
Yes.
But a
Absolutely.
nurse couldn't.
That's right.
Right. Even though she
that's-
is licensed and
Right,
it's
right.
crazy.
And also
The common sense
assisted
don't
living
like that.
also assisted living facilities don't have aren't required to have AEDs right now, defibrillators. So
Really?
I'm working on that one too.
That's part of the common sense.
Well, I was gonna make it part of it, but then
Although they also, if someone falls, cannot actually pick
That's
someone
right.
up off the floor. So you can't sort of assess the patient. Oh, I just kind of slid out
Yeah.
of bed, using an example. They can't. They have to call 911.
Oh, that's why there's our fire chief in Marlborough. That's one of his favorite lines is we put the assist in assisted living because that's their regularly that's one of the concerns in the communities. They're constantly being called.
You think
but
about the
it's because,
expense of that, and versus, I mean, a clinician being able to assess clearly this person has fallen, they've hit their head. We've got to utilize emergency services versus
right, and then the fire truck shows up. And it's like, what is this?
right.
So those are some of our small failures, but I am hopeful that we'll be able to get them done at some point. Obviously, our large success was the sort of what you're calling the omnibus Alzheimer's bill. So back in the fall of last year, so September or October, we had a joint committee hearing with the Committee on Public Health and the Committee on Elder Affairs, and it was by invite only, and we had experts from the field. We had Secretary Bonner, we had medical professionals, we had Trish Pope from the Marlborough Council on Aging came in and spoke about the dementia-friendly programs that the 4 communities have been working on. And from that, we were able to then take several bills that were kind of floundering in either elder affairs or public health and put them together in one big bill. I think at the end of the day, there were like 10 or 11 pieces of legislation that were filed individually that we ended up somehow putting into the bill that we passed. So the bill encompassed, at the end of the day, I think 6 sections. The first section, the most important section in my opinion, created an advisory council at the state level with stakeholders, as well as tasking them with coming up with a state plan on how to deal with future issues arising out of Alzheimer's disease.
Forward thinking.
And with the rise in incidents we have with folks, and it's not just Alzheimer's, it's also Alzheimer's and related dementia.
Sure.
We should, every time I say Alzheimer's, it's not just Alzheimer's.
Right.
Because I did have some people reach out to me and say, what about Lewy body dementia or all these other things? And they are all encompassed within that.
Right.
So, like, one bill that we didn't get a chance to put in because of some technical issues was covering folks with early onset Alzheimer's, because we're now seeing an increase in people that have Alzheimer's diagnoses from, believe it or not, the early age of 40 on up, and those are people that still should be working, and their families still should be working, and it creates all kinds of other issues. So that was one of the most important tasks that we have handed to the advisory council, to try to figure out a way to get some support and coverage for those people. The second provision that I'm the most proud of is something that we put in to deal with the lack of diagnosis, because we've found that approximately 50% of people who are dealing with Alzheimer's or related dementia are unaware of it, whether it's that they haven't been diagnosed and their doctor hasn't told them, or they have been diagnosed and they don't have the capacity to remember that diagnosis. And as a result, they're not taking care of their comorbidities, whether it's heart disease or diabetes or all these other things. They don't remember to eat. So we really wanted some training for the physicians. And they did push back with us on that a little bit.
The physicians do.
They are now required by law to take, as part of their continuing medical education, to renew their license every 2 years, a part of their CME, continuing medical education, in Alzheimer's and dementia diagnosis.
Fantastic.
They didn't want to do it, but we kind of said, I don't really care that you don't want to do it.
And their reason was, we got too many things to do.
That's right. And there was another whole organization or a group that said, well, what if I'm, an OBGYN, or what if I'm not an eye doctor?
Right.
But the bottom line is, all physicians need to know how to deal with this in one way or another, because if you have, even if you're an
A family
OBGYN,
member, right?
what if you have a pregnant woman whose mother has Alzheimer's, and
Sure.
you just need to be able to take all of these things into consideration.
No, I was going to say the familial impact of someone coming in and to sort of just say, well, that doesn't apply to this person that
That's
I'm looking
right.
at right in front of me is
At the end of the day-
naive at best.
That is so good.
Yeah.
I mean, to have the whole profession,
Yeah.
no matter, because they're always talking to each other. So to have somebody
Right.
to be able to say, well, you know, I spotted this.
Right. And it might not
suddenly-
be my area of expertise,
Yeah,
but
but I know that there's trouble here. That's right.
Right.
That's right.
And it's not just the physicians, it's also the nurses and the nurses' assistants. So those were
As
two.
part of their licensure.
That's right. So
That's
it's
great.
two of the sections of the bill that I'm really proud of. And you're right, it's the familial impact, because Massachusetts as a whole, whether it's the people with the disease or their familial caregivers, we're looking at between 500,000 and 1 million people across the Commonwealth. And it's a huge impact, not only on the people as far as their healthcare decisions, but financially. Because caregivers that have to go from working full-time to part-time or part-time to no time,
Right.
and especially with the early onset,
Yep.
those are folks that are typically working age.
Sure.
That's right. So they're falling right out. Now they're on SSDI.
Mm-hmm.
They're no longer able. They're no longer able to. But as you say, it's a family disease.
That's
now
right.
all the care, because there's a ton of care involved.
That's right.
So those caregivers had day jobs, but they don't anymore.
That's right.
And I also think by training all of the medical professional staff, you also sort of start to peel away those veils of we just don't talk about it, or we don't talk about it because we don't understand it, or it's not kind of, again, my wheelhouse. So I mean, not unlike the conversations we're having around mental health and opioid addiction, et cetera. I mean, the more we understand it, the more we might spot, signs of stress, and are you aware of this resource, or let me connect you with someone. So.
Which leads me to the final two sections of the bill, which
Oh, what a
one
great segue.
Well-
was a
Wow,
good
that was
Did we
a
segue.
rehearse?
right?
I knew the rehearsal was worth it.
Thank
Right,
goodness.
that's great.
We are requiring training of elder protective service workers as well, so that they can spot the signs of abuse of folks that are dealing with these diseases, whether it's familial or whether it's a caregiver or whether it's someone in the community, because there's financial abuse happening, there's physical abuse happening, and then it's the stress level on the caregiver.
Right.
I mean, it's a really, really tough thing, and the thing is, walk around and you're going to be lucky if you don't come on somebody who has dealt with this experience,
Absolutely.
either as a caregiver or as a friend of everyone in the Commonwealth has been touched by this.
Right.
And everyone hopefully in the Commonwealth will be touched by the provisions of this bill. And then the last provision,
Excuse me, just step back. So family protective service. Who is that exactly?
so it's basically, we have a 1-800 number in the Commonwealth that the secretary always talks about, and I should have brought the pamphlet so I could tell folks what the 1-800 number is.
I bet that we can get that as a banner on the show. I bet that.
That would be great.
I bet that our
So
friends in
there's
the
a
back office
1-800
can
number
take
that folks can call if they suspect that an elder is being abused, and it can be anyone.
Right.
And
Right.
the law has changed such that the first thing that the hotline folks will do is then call that elder and try to figure out whether they feel that they're being abused. And traditionally, before the law changed, that elder could say no, and then the investigation would close, and that would be it. That is not the case any longer, which is causing a budgetary problem for the folks that provide these services, like at Bay Path Elder
Sure.
Services. So we're working on that. We're working on getting them some increased funding, but now they have to continue to investigate the case at least a little bit further, because the concern would be that the elder says no, because either they don't know,
Right.
or because they're afraid of whomever their abuser
That's
is.
right.
And I
That's
think
right. Or
it's-
they're just wondering who is this person that's calling me right now?
That's right.
Right.
What
So-
is this agency? Am I going to get taken out of my house?
That's right.
I think that's probably one of the greatest fears
Absolutely.
around folks who have got dementia is, oh my God, if I get discovered, I'm going to end up in this nursing home bed
That's
in,
right.
in the middle of nowhere. And
And
right.
sometimes the thought might be, sadly, even though I'm not happy with the treatment, it's better than being someplace else. So we will get that number up as a banner, but so the elder abuse hotline is staffed by our friends at the various ASAPs, right? So here in Westborough, that would be Bay Path Elder Services, and other places it's Elder Services of Worcester, et cetera, right?
Right.
And I think it's important for our audience to know, and you already mentioned it, but there are different types of abuse. And while we won't sort of go into all those, I think it's important that there's abuse we all think of, like it might be verbal or physical. That's pretty obvious, of someone grabbing someone and kind of saying, come over here. And those are the ones that unfortunately make headlines and all of that. But there's also financial abuse, and that could be very subtle and in some ways scary, because there are no signs. There's not a bruise or a mark on an arm, but someone could be liquidating assets at a very slow percolator drip, if you will. So it sounds like you've got
We've
some.
also seen increases of that with the growing opioid crisis.
Right, absolutely.
The
Oh, yeah.
impact on elders has been huge.
I've seen
in
that.
a
I've
negative
seen
way.
that. I bet I could give you half a dozen cases
Absolutely.
with a son or a daughter
So-
who's living at home often.
Yep.
And next thing you know, they're on the checkbook.
So that was
Right.
another bill that we're trying to
Tough.
look at, establishing a commission on exploring financial abuse of elders and making mandated reporters of banks and things like that, so that when they see that, Mary has been writing checks for the last 10 years to cover the rent, the gas, the electric, the phone, and the groceries, and then all of a sudden Mary is now writing out a $500 check every month to John, how do we determine whether that's abuse and give somebody the power to investigate it?
Sure.
Now that's really interesting.
Yeah,
So you make
yeah.
the banks a reporter. That's a great idea
That's
because
interesting.
that's of course that's where the finances happen.
That's right.
And one of the issues that I'll always tell people when they come in is that, the issue with financial abuse is typically the people taking the money don't have the money still. Right?
No,
So you
it's
can
gone.
never get it after the
never-
fact. That's a
that's right.
set of players from which when the money's gone, it's gone. So
right.
so this notion of having a kind of a strategy really
For damages or
that-
something. Yeah.
forget it, that's irrelevant. So
Right.
the key is to keep it from happening.
That's right.
Or to minimize it.
Right.
To minimize
Right.
it.
Yeah. Absolutely.
Now is that the last section of the bill?
It's not. That was one of the other
one?
ancillary bills.
Yeah.
The last section
I
of the
thought it was
bill.
my memory and I had forgotten.
No,
I
no.
forgot.
That's
Just
good.
making
You're right.
sure.
We were testing
Arthur,
that.
I
if I
always
had
tell-
a nickel for every time I heard one of those, I forgot jokes during this whole Alzheimer's
Oh, I bet.
process. Oy
Well, I
vey.
always tell people the wonderfulness about getting old, though. This is just an advantage, right? Is that I never could remember people's names and any of this stuff. Now I can just say, "Oh, I'm old."
Oh,
Right?
I always
Before
just
it
said,
was
oh,
like,
I was
boy,
having
you're such
a
a
blonde
dope.
moment.
Yeah, well. So last section.
So we worked with the hospitals, and there was a 3-year commission that studied how we implement better practices around Alzheimer's and dementias in acute care settings.
I see.
And as a result of that, the hospitals actually were the first folks on board with this bill, the first provision that we got nailed down, to give them 3 years to create a comprehensive plan on how to deal with folks with Alzheimer's and dementia that are coming into the hospital, either through the ED or through the general intake process.
Even if they're not coming in necessarily because of the dementia, but because of something else.
That's right, but largely when someone has a dementia, they're coming in because of the dementia, because they've forgotten to take their meds, or because they freak out and they don't know where they are, or because of something that's happened that's related to their dementia.
Right.
And often they're treated like they have a mental health issue, or like they're on some kind of a substance,
Yeah.
or they're just shoved in the corner.
Just like the police will tell you. One of the things that the police want the training is when they do a police stop, you've got somebody who's
That's right.
driving, has got dementia.
And they're on the wrong side of the road, and you automatically assume
You
they have
assume.
substance, and
Exactly.
that's not what it is
Because
at all.
that's how they react too, because they'll be yelling and,
That's
what
right.
are you doing? And
That's
same
right.
thing.
Right.
So we have given them 3 years to come up with and implement these plans, and then after the 3 years goes away, the DPH is then allowed to step in and require that they show the plans and demonstrate that they have the plans in place. So it goes hand in hand with the physician training piece.
So it's not just developing the plans; it's actually implementing.
That's
them.
right.
And are there checkpoints along the way for the hospital systems?
There are not.
They're not.
So
Okay.
we kind of gave
Okay.
them a lot of leeway,
Okay.
and
Yeah.
basically the DPH has the teeth to go in at the end. So if they know there's a hospital having a problem,
Mm-hmm.
they then have the enforcement authority at the end of the process, and
Do
they can
something.
And
go
what
in.
is that enforcement authority? I
So
mean,
they can go in after 3 years and 1 day and say, where's your plan? Oh, wait, you don't have a plan here, because there will be, plans that they can get from other hospitals and help these hospitals that are having
Right.
trouble implement.
But I mean, are there financial penalties to a hospital to
There
not
are not.
implement that? It's more of a.
They're not
Yeah, but
right now.
But
But if
DPH
we,
is the ongoing relicensing authority regarding the hospital. so-
that's right.
Right,
And
right,
I
right,
mean,
okay.
obviously,
Yeah.
again, at the end of the 3 years, if we see it being a problem, we can always go back
Yeah.
in
I
I mean,
and
I think
change
the
it.
reason why I ask about the financial piece is, at the federal level, obviously with readmissions, as part of the whole Affordable
Yep.
Care Act, there were those penalties. So I just didn't know if there was the same
No.
thing. Okay.
So, and to me, when you describe that, I think one of the nice things about that is that they're not mandating a plan.
Right.
right.
So letting each hospital, so that because kind of by definition, you don't know what you don't know. So it'll be really interesting at the end of those 3 years to
Yeah.
see what the hospitals have come up with
Right.
in terms of how they want to approach those.
Best
those-
practices,
And now
yeah.
suddenly you'll be able to develop a best practice strategy out of that. That's
And
really good.
also, there will be implications of whatever happens with question 1 in November that will play into what happens with this plan development.
Right.
Because obviously, either way, the financial impact on the hospitals after what happens in November
It's gonna be huge.
will.
And for
have-
folks that don't know, what is that
Question
question?
So, question 1 would require a certain high limit on how many patients a nurse in a hospital can serve across the board.
At any moment.
Right.
That's right.
Right.
A patient, a nurse
That's right.
staffing ratio.
That's right.
Excellent.
A great challenge.
Yes.
That one's a great.
We're not talking about that one today.
We're not,
Yeah,
we're not,
no,
no,
we're
we're
not.
not going to go there. I remember being on the board at the hospital, at Marlborough Hospital, and that was came up several years ago.
Well, we did independently, legislatively, 3 years ago, I think, put in a ratio for ICU patients.
Right.
So we legislatively handled that, and apparently some folks were not happy with that.
And so we're going to see where that
isolated.
goes.
Actually, speaking
ratio.
of people not being happy, but as it relates to the hospitals, and so this is a 3-year plan, but as life goes in politics, as there are changes and potentially new majorities come in, can that plan be pulled back, or is that sort of stamped and mandated? How does that sort of practically work?
I mean, I think we would just rather, I think that along with the advisory council and the state plan, I think those plans that the hospitals might be allowed to have can fluctuate as long as there is a plan. I would love them to be able to make changes to it because
Yeah.
they can make changes that benefit people as
They
they see
can't,
fit.
they can't, I mean, I guess what I'm saying is if a new majority comes into at the state level, can they say, oh, that we're gonna
Oh
go
yeah,
all
that's
over
always
there?
possible.
That is,
you know,
okay, so they
our
could,
only legislation in the Commonwealth of Massachusetts that's absolute is our Constitution, and that's not really even absolute because it can be amended.
Right.
Okay.
It's a
So it could always
process,
change.
but
So that is,
everything
but
is.
someone would have
yeah.
to sort of take that up as an initiative. And,
That's right.
I got it, okay.
So in the course of all of this, you've obviously learned a lot about this notion of dementia-friendly communities and kind of
Yes.
what that kind of community is and what the components are to it.
Right.
So, and I know kind of early on, one of the things that Shelby was asking was based on all of kind of the things you've learned. What do you think? Where do you think things should be going? You know, given the fact that there are always there are a ton of constraints.
That's right.
But in
So-
terms of your knowledge now, as opposed to 2 years ago, going, oh my God, right now you really are in a position to say, oh, this is where the dream it really should be going here.
So I first commend the towns of Northborough, Westborough, Hudson, and the city of Marlborough on their work on dementia-friendly communities. I think it's been groundbreaking, and the thing that I'm most proud of all of that is you've heard me speak to the training of the students at Assabet
Yeah.
and making sure that our kids at our tech schools, not just the CNA students,
Right.
but the students in the auto body and the students at the Epicurean room are all trained.
Right.
On-
First in the state. That's a
It's-
wonderful,
It is
amazing
amazing.
program.
It's an amazing program, and I should have mentioned at the beginning that our Alzheimer's bill is a first in the nation bill. So I've already been getting calls from around the country about how they can implement what we're doing. So the dementia-friendly programs are fantastic, and that was one of the first things I was taught about as I came into Elder Affairs. And then almost immediately thereafter, I was invited to a Tufts Health Plan Foundation day-long event on age-friendly communities. So it expands the scope and doesn't necessarily just focus on dementia-friendly communities, but obviously folks with dementia
Are
or
inclusive.
Alzheimer's would be included and encompassed within that. This can include, but is not limited to, things like having an over 55, like it's going to go in at the old Westborough State Hospital,
yep.
and having directly adjacent a CVS, a grocery store, a Target or whatever, some kind of recreational facility, but having no sidewalk within the community so that the residents can get from their residence to that facility, and having to bus people an eighth of a mile when they could very well be walking, which is actually good for them anyway.
Sure.
Right.
So we're talking about those things as far as age-friendly goes because we've lived in siloed ways for so long that we build these new communities and we think, oh, this is great,
Right.
and then we don't realize until after everything's built and the ground's already broken and the ribbon's already been cut that, in fact, it could have been so much better if we had just planned it correctly from the
Right.
beginning.
Right. And of course, the private sector isn't going to solve that for you because they're thinking about the marketing of their
Per
one
unit.
thing.
Right.
You know, if I'm in the senior housing construction business, I'm not in the drugstore business. And
Right.
I'm not in the other.
That's a prime example. We already have actually right here in Westborough with the Willows, the folks in the assisted living facility over there. Try getting them across the street to
Right.
Tatnick
Yeah.
or to any of the stores that
That's
are
right.
there at their disposal.
It's a high
without,
fatality rate.
Right,
Yes.
right, right, right. Yeah,
Exactly.
I mean,
right.
hindsight being 2020,
Yeah.
we could have done something better
Right.
to make that more livable for those folks.
But that's, I think it's important that we're all having those conversations because now planning boards can reference, kind of what state level work is being done. And if you're building a home, I mean, again, you're kind of concerned, you're building a development, I should say, you're concerned about that kind of per unit cost and how do I
Yeah.
make my money back? I mean, that's real. But if everyone sort of is sort of universally understanding the issues, then, you know, you really can create win-wins, because that's gonna, I mean, if I'm Pulte, who is the builder of the state hospital project, you know, I want people to continue to move in there,
That's
because
right.
ultimately people are gonna age out, or, right, so.
That's right. That's right. And if you're Westborough, you know, you've done something like what you did downtown
Yep.
with the old factory site that has really been, given what you were trying to achieve, you did that, you know, but now we're kind of looking at something different that you can try to achieve. And
Right.
if you're doing it from that higher level,
That's right.
that's great. That's really exciting.
Yeah,
That's really
great.
exciting. So Danielle, that was really great. This is wonderful that,
Thank you.
that you thought to
Thank you
invite,
very much.
you know, it's wonderful.
It's
And
great.
Thank you.
just terrific. And to
Thanks
give
for
a
having
lot
me.
of folks here a sense
Yeah.
of kind of what's going on there.
Yeah.
Thank you very much,
Thank you
Shelby.
for all your work at the.
Also, maybe we can put a banner of our contact information that we want
Absolutely.
in case anyone wants to get a hold of us.
Absolutely. Thanks
Great.
again.
Thank you.
Thank you.
Thank you.
Thanks for tuning in, and we'll look forward to seeing you next month in the next installment of Frank and Mary in Westborough. Thank you.
Thank you.